Hello and welcome to the Clinical Update podcast, a podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Dawn, medical editor at MIMS Learning, and here with me is my colleague Rhiannon, deputy editor of MIMS Learning.
Hi Dawn.
Hi. So today we'll be talking about our new editorial campaign, Confidence in Obesity Care. We will be looking at the aims of the campaign, what topics we hope to cover, and what we already know about obesity. And we will be discussing learnings we have from our existing modules on obesity and its related conditions. Before we start discussing our new campaign, let's just go over why MIMS Learning runs campaigns and what campaigns we've done in the past. So our general goal at MIMS Learning is, as our podcast intro says, to bring GPs and other healthcare professionals thought-provoking clinical education. Recognising that healthcare professionals need to know about a whole range of conditions, we cover a lot of topics. For example, we have sections on cardiology, dermatology and mental health. However, we also recognise there are some hot topics that warrant a deeper focus. So we have done campaigns on skin of colour, health inequalities, and most recently, earlier diagnosis of cancer. Rhiannon, you led our cancer campaign. Can you tell us a little about it?
Absolutely. MIMS Learning's Patient Presentation Pathway for Cancer campaign provided focused support for primary care healthcare professionals to identify at-risk patients, spot signs and symptoms of cancer, and make best use of referral pathways to optimise early diagnosis.
I mean, the campaign's been very successful, hasn't it? So it's had 8 charity partners and was recognised within our organisation for its impact.
That's right, yes. It's been very popular with our readers and our listeners. And as she said, we've had 8 wonderful charity partners who we're very grateful to for their support. And it's too early to know whether we might get any other awards for this campaign, but our Health Inequalities campaign from 2024 won the prestigious Publishing Award PPA's Campaign for Good. So fingers crossed that we'll have some success with this one as well.
Yeah, so the success of the past 2 campaigns does inspire me to make confidence in obesity care the best it can be, but it also makes me feel somewhat intimidated, so eek.
Yeah, awards are a good thing to have, of course, but obtaining them is not the point of the campaign, of course. So why are we running a campaign on obesity, Dawn, and what are its goals?
Well, unless you've been living under a rock, you'll know that obesity has been a hot topic of late. I mean, this is thanks to the advent of weight loss medications. Prior to these medications, there wasn't much a GP or another healthcare professional could do to directly treat obesity. I mean, they could advise on diet and lifestyle, or in selected patients, refer them to bariatric surgery. But aside from all of that, which I think can have unpleasant side effects, there weren't any specific medications for obesity. Now, though, there are these specific treatments which patients are very much aware of and asking GPs about. So one of the goals of the campaign is to provide education on these medications, how they work and which patients are eligible for them. Importantly, though, we also want to encourage GPs to recognise that the management of obesity is so much more than prescribing a GLP-1 medication, which of course is a weight loss medication. So it's about seeing the person, not the BMI, a person with individual needs.
Absolutely, and treat the person, not the condition, is an important goal, whatever medical condition we're talking about, and something that primary care is in a great position to deliver, though that can be hard to achieve given how stretched GPs are at the moment. So let's talk a bit about what obesity is. Obesity refers to a BMI of 30 or more for people of white European ethnicity, and a BMI of 27.5 or more for people of South Asian, Chinese, other Asian, Middle Eastern, Black African or African Caribbean backgrounds. Now, the latest stats indicate that a considerable number of us in England are obese. About 30% of women and 28% of men live with obesity. And if you include the stats for people who are overweight, that encompasses a majority of men and women in England.
Okay, so let's look at why people might be obese. That, of course, is a very complex question, but according to our module on obesity in adults by Dr. Pipin Singh, there are some medical conditions that predispose someone to obesity. These include endocrine conditions such as Cushing's syndrome or hypothyroidism, and genetic conditions such as Prader-Willi syndrome. There are also drugs that can lead to obesity, such as mirtazapine, glycoside, and certain antipsychotics. Dr. Singh, who I should point out is the medical lead for our campaign, also outlines the risk factors for obesity. These include family history, mental health disorders, such as depression, anxiety, or psychosis, and poor diet with high fat intake.
Addressing poor diet is difficult for the healthcare professional, though, isn't it? And they can discuss diet at the individual level, but they can't do much about the wider issue of our obesogenic society. But the government is attempting to. It's planning to restrict junk food advertising targeted at children and to ban the sale of high caffeine energy drinks to under 16-year-olds. And it's extending the sugar tax, or soft drinks industry levy, to give it its formal name, to include prepackaged milk-based drinks with added sugar. Plant-based drinks like soya, oat and rice drinks with added sugar will also be taxed, but to reassure the dairy-free and vegans among us, the key word is added sugar, so unsweetened plant-based drinks won't be taxed.
Right, so those are some of the risk factors for obesity and what the government is doing to address them. We haven't yet discussed why we are so concerned about obesity. Now, most people, whether they are medically trained or not, understand that carrying excess weight isn't good for your health. But let's just go over some of the complications of obesity. They include type 2 diabetes, cardiovascular disease, certain types of cancer such as endometrial cancer or breast cancer, endocrine conditions such as polycystic ovary syndrome, and respiratory conditions such as obstructive sleep apnea. Obesity also leads to delayed healing with respect to infections and can lead to increased post-operative complication rates and increased recovery times.
So during the campaign, we'll be looking at these complications in more detail. In fact, you just mentioned obstructive sleep apnea, Dawn, and I believe you've just had a module on that updated, haven't you?
Yeah, that's right. Dr. Singh did the update. We are also planning to update our module on the NICE type 2 diabetes guidance, which at the time of recording is due to be updated in February 2026. Also, on our campaign page, we already have modules on several conditions related to obesity. These include cardio-renal-metabolic disease, a practice on the page on gynecomastia, and a module on young-onset type 2 diabetes.
Shall we talk a bit more about cardio-renal-metabolic disease then? Because it's a relatively new concept, isn't it?
Well, it is and it isn't. So cardio-renal-metabolic disease, or CVRM disease as it's often called, refers to the intertwined pathophysiological relationship between cardiovascular, renal and metabolic conditions. Now, metabolic refers to a broad range of conditions, but includes many that are indirectly or directly related to obesity. I mean, the term CVRM is relatively new, but the idea that somebody can have multiple conditions that can interact with each other isn't new, and nor is the idea that having multiple conditions is associated with worse outcomes than just having one condition.
Yeah, okay. And are weight loss medications a treatment for CVRM?
Well, it depends on what conditions that person has. So if they have type 2 diabetes, then they might be eligible for GLP-1 medications, aka weight loss medications. However, the strength of GLP-1 medications that are used for type 2 diabetes is a fair bit lower than the strength used for obesity. So unless they have a specific obesity indication, a person with CVRM would not receive a GLP-1 at the dose used for weight loss.
And someone with CVRM could potentially also receive an SGLT2 inhibitor, again, depending on what conditions they have. I think this is why in recent years there's been so much noise about SGLT2 inhibitors and GLP-1 medications, because they can both be used for multiple conditions. In fact, Dawn, you mentioned the upcoming type 2 diabetes guideline. Is the thinking that when that's finalised, SGLT2 inhibitors will become a first-line option alongside metformin for type 2 diabetes?
Yeah, I think that's the current plan, and I don't think it will change, because when the draft update came out in August of 2025, it was broadly welcomed by healthcare professionals. But on the subject of type 2 diabetes, shall we discuss young-onset type 2 diabetes? Now, this refers to type 2 diabetes that occurs in people aged younger than 40 years, which I found rather upsetting, as it now means I'm too old for young-onset type 2 diabetes, though not that I particularly want type 2 diabetes, really.
No, exactly. Young onset type 2 diabetes is on the rise, according to our module by Dr. Rhiannon on the condition. The incidence in the UK is rising faster than anywhere else in the world, which is slightly concerning. But when we say young, we are still mostly referring to established adults. Most cases occur between the ages of 26 and 39, with only 1.3% of cases occurring in people aged 18 or younger. So on the whole, we're not talking about children or young adults here.
Either way, as with type 2 diabetes of typical age, young-onset type 2 diabetes is closely linked with obesity. Nearly 90% of children and young people with the condition are overweight or very overweight, and 74% of all people with young-onset type 2 diabetes come under these categories. Now, what is important to note is that the condition is associated with worse prognosis than type 2 diabetes of typical onset. This is in part because of the longer duration of metabolic dysfunction and hyperglycemia in people with young onset type 2 diabetes. Management depends on the age of the patient. If they are 18 or older, then the management is similar to that of someone with type 2 diabetes of typical onset. However, it gets more complicated for younger patients, and specialist input might be required as fewer licensed treatments are available for people under the age of 18. Okay, so we have discussed the risk factors and complications of obesity, but what is the role of the GP in all of this?
Well, the first step is addressing the issue. Given the risks associated with obesity, healthcare professionals do have a duty of care to ensure that patients understand the risks and that support is available should they want it. Now, ideally, the patient is the one who raises the issue. Dr. Singh writes in his module on obesity that if patients are the ones asking about weight loss, they may be more likely to engage with advice about weight loss and may have even started to engage with the process themselves already. However, often healthcare professionals will raise weight as a concern when discussing another problem that the patient's presented with. And the patient's weight could be linked to their presenting condition or maybe a secondary issue that the GP wishes to raise. Now, obviously, discussions about weight do have to be handled sensitively.
Yes, so now bless my late mum. She, like many people, was not fond of being lectured. She lived with obesity and she tends to avoid going to the GP because whatever problem she had, she thought, oh, they're just going to tell me to lose weight because they're just going to blame the problem on my weight. Now, I'm not sure whether a bad experience put her off or it was just the general stigma around obesity. But for whatever reason, she didn't always seek the help she needed. And I think there were occasions when she let a problem get quite bad before she sought help. The point is that if conversations about weight aren't sensitively handled, the patient might be completely put off from seeking medical advice when they need it, let alone for weight loss. NICE, in its obesity guidance, talks about the principles of care with respect to obesity management. These are respect me, support me, understand my life and feelings, and help me during our consultation.
Indeed. And in his module, Dr. Singh outlines tips for both speaking to a patient who has asked about weight loss and speaking to those who've presented with a different issue. So do take a look at that. Shall we move on to management now? Weight loss medications are just one option for weight loss management, and they're not even the first step. But given the media interest in them recently, they may well be what a patient will want to talk about. So GLP-1 medications, which as we mentioned earlier are what we're referring to when we say weight loss medications, have been around for a while and are an established treatment for type 2 diabetes. However, to recap, more recently, higher strength versions have become available and can now be used for weight loss. And really, we're just talking about the GLP-1 agonist semaglutide and the dual GIP and GLP-1 agonist tirzepatide.
Yeah, but let's not go into too much detail about them because we will be covering GLP-1 medications in greater depth later on in the campaign. But we should point out that GPs can't prescribe Wegovy, the weight loss version of semaglutide, as only specialist weight loss services can. While they can prescribe tirzepatide for obesity, only patients with the greatest need, as determined by the NHS rollout programme, are eligible for it. Currently, that is patients with a BMI of 40 or more and at least 4 specified comorbidities. These are cardiovascular disease, dyslipidemia, hypertension, obstructive sleep apnea, and type 2 diabetes. So I imagine GPs have to manage their expectations somewhat and say to some patients that although there are now drugs for obesity, they are not eligible for them. Now, there is ongoing concern that patients, whether they are obese or not, are buying weight loss medications online, some from less than reputable sources. So GPs and primary care professionals do need to be aware that potentially some patients are taking these medications and haven't told them.
Even if a patient is eligible for tirzepatide and is available in the local area, because that's another consideration, of course, they are still going to need advice on lifestyle modification. GPs can refer to behavioural overweight and obesity management services, and this includes professional supported services and will vary from area to area, but can also include national programmes such as the NHS Digital Weight Management Programme and the National Diabetes Prevention Programme. So the NHS Digital Weight Management Programme supports adults living with obesity who also have a diagnosis of diabetes, hypertension or both to manage their weight and improve their health. It's a 12-week online behavioural and lifestyle programme that people can access via a smartphone or computer with internet access. And there's the Healthier You NHS Diabetes Prevention Programme. And this identifies people at risk of developing type 2 diabetes and refers them on to a 9-month evidence-based lifestyle change programme.
There's also the infamous soups and shakes diet, or to give it its technical name, the NHS Type 2 Diabetes Path to Remission Programme. Eligible participants are offered low-calorie, total diet replacement products, including soups and shakes, so that they are consuming overall 800 to 900 calories a day for 12 weeks. During this time, participants will replace all normal meals with these products. Alongside this, participants will receive support and monitoring for 12 months, including help to reintroduce food after the initial 12-week period. A few years ago, this diet was much lauded because people were losing so much weight that they reversed their diabetes. But the major issue was maintaining the diet. It's very restrictive, so you can't do it for long, and nor should you. And of course, if the diet ends and somebody goes back to what they were eating before, the weight comes back on.
Indeed. And we made a brief reference to surgery earlier, but we should probably just go over that. So several options are available, such as gastric bypass or gastric band. And as with GLP-1 medications, not all patients with obesity will be eligible. Referrals should be offered if adults have a BMI of 40 or above, or 35 or above, and a significant health condition that could be improved if they lost weight, and if they agree to the necessary long-term follow-up after surgery. However, it's worth noting that referral can be considered at a lower threshold for people of South Asian, Chinese, other Asian, Middle Eastern, Black African or African Caribbean family backgrounds. And this is also true of weight loss medications.
Okay, let's leave it there. Thanks for joining me today, Rhiannon. The campaign will run for the whole of this year, so we can look at things in more detail throughout the year. What have we learnt today, though? The MIMS Learning Confidence in Obesity Care campaign will run throughout 2026. The aim of the campaign is to enable GPs and other primary care health professionals to support people living with obesity more confidently. It will have CPD modules from podcasts to in-depth clinical reviews on managing obesity and its related complications. Most people, whether they are medically trained or not, understand that being obese isn't good for your health. The complications of obesity include type 2 diabetes, cardiovascular disease, respiratory conditions, and some cancers. Obesity also leads to delayed healing with respect to infections and can lead to increased post-operative complication rates and increased recovery times. Selected GLP-1 medications can be used to directly treat obesity. Which healthcare professionals can prescribe them and which patients can receive them depend on the individual drug. Currently, the dual GLP-1 medication tirzepatide is being rolled out in primary care to those in the greatest need. However, the management of obesity is much more than weight loss medications. Healthcare professionals should ideally treat the patient, not the BMI. Thanks for joining us today. Don't forget you can claim CPD credits for listening to these podcasts, and there are plenty more on the MIMS Learning website. We have been the MIMS Learning editorial team, and this episode was produced by Jude Owen. Look out for our next episode when I will be speaking to Jane DeVille-Almond from the British Obesity Society about supporting patients on GLP-1 medications.